Oh, yes, this microphone. This
Oh, wow.
clip is on.
Yes. Is that high? Is that low? Where does it go? Where does it normally go?
Yeah, no, like
Hello?
around, it's
Hello?
Like lapel. Yeah. Doesn't make it.
Wow, I'm up amongst the grades.
Yeah, feeling it.
Thanks, guys. We're going for PewDiePie. We're gonna take him. All right. I don't know. Get started? Don't get started?
Yes.
Get started. Money box? Are we charging?
No. That's just for Metro.
Wow, okay.
30 tickets yesterday.
Did you?
Yeah.
Nice. I'm gonna buy a few. I have to buy a few.
Yeah. I also bought 4 for my parents today. Yeah, my 4 parents. Yes.
Okay. So moving on from Michael's therapy session. Hi guys, I'm Neela. So I'm just giving MSK, which to be honest is decently straightforward. So I'm going to try and get you guys to practice a bit as well. Okay, general game plan. The key stuff for OSCEs, everyone probably has told you by now you'll get like normal exams, memorize the summaries for like a normal exam so you're really confident with that. Just kind of routine, like do your exam like 6 times in a row or 7 times in a row, like the abdo exam or MSK exam or whatever else, so you're just really smooth with it because that's sort of the stuff that's going to tell your examiner like you've done this before. So my sort of general approach to this was like, I'm just going to do the stuff that's going to like show that I'm prepared or like show that I kind of have done this consistently throughout the 2 years even though I hadn't. So there's like the super basic stuff, wash your hands, consent, introduce yourself, the communication stuff in your history. I know this is about exam, but I think history is really what passes you. Like they want to see that you're someone that has communication skills, and then the exam, they know that you're still learning it. So as long as you look like you've really tried and put in some effort, I think they'll pass you. And then it's just sort of P+ stuff. So I got P+ in pretty much most of my OSCEs, and I think it really just came down to the Viva questions, which were basically all past questions. So I'd like know the next question he was going to ask before he even asked it, and I was like, this is sweet as. So yeah, just make sure you kind of like go over all the MedConnect stuff and really just like do the answers a few times, and then you'll be really sweet, and practice it. That's pretty much it. So we'll do MSK. So we've got hand and wrist, knee, and then a bit of MSAL. All of them are just going to be look, feel, move, and then a few special tests, which are usually just testing function. So even in 3rd year, like we do shoulder and hip exams, and I still use the same thing now, and all the orthopods tell us to use the same thing, like they think of it the same way. So it's a really good way to like kind of remember all the steps in your exam. So with hand and wrist, wash your hands, blah, 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 consent. Have a kind of the same way you memorize your summary, have a little bit of a spiel for how you explain it to the patient in kind of like a nice, concise way. So whatever, like I'm just going to be looking at your hands, having a feel, getting you to move them, and then seeing how your coordination is, for example. So expose the patient's arms if necessary, kind of ideally they'd be wearing like a short sleeve shirt, but maybe even if they can roll up their sleeves, and then put their hands on a pillow. Before you start, ask if they have any pain right now, and then we inspect or we look. So it's probably good to know the deformities that are on the thing. I'll put up the slides if anyone actually goes back and sees them, but you have the 2 for osteoarthritis, and it's just kind of the different joints that they're affecting, whether it's distal or proximal. The ones for RA or rheumatoid are the swan neck one that you can see, and boutonnieres. They're again just affecting different joints, and then they'll also have the ulnar deviation. That'll be really obvious once you've got their hands. So my OSCE patient was RA, so like she had hands like on the pillow, and it was just like straight out sideways, and then like a whole bunch of like just deformities everywhere. You do a history and an exam, so they'll probably give you an OA or an RA or something, and you'll already kind of know by the time you've done your history, because they're pretty straightforward signs. Look for other things, so surgical scars, swelling, skin changes, muscle wasting, asymmetry. Muscle wasting will be most obvious kind of with your thumb muscles. So if you have carpal tunnel, you'll get wasting of your thenar eminence, yep. And most importantly is kind of asymmetry. If something looks different on the other side, it's probably not normal. Cool, so then the next one's feel. So we start with hands, then we start with wrist. So palpation, so you squeeze across the joints here, the MCP joints, and then you kind of go with each IP joint on each finger. You look at their face as well to see if they have any pain. You can tell them before you start as well, let me know if any of these are painful for you. So you do that with all of your different joints of your hand, and then you can passively move it. So all you need to do really is passive movement. So you're flexing all your joints. So what we learnt was just to kind of curl up your fingers one at a time. Some people kind of do them all, but I think one at a time is supposed to kind of differentiate where's the pain and localize everything. When you're squeezing the joints, so like it says there, what you're assessing for basically is it a bony change? So that would be something like you might see in OA, osteoarthritis, or is it the boggy swelling that we talk about in RA? And boggy basically just means it's a bit spongy. If it's very soft and tender, then you're thinking inflammation, so something like a bursitis. So those are sort of things you want to look for. You might want to also feel kind of for temperature, but that's kind of more relevant for the leg exam because you've really got more space to work with. Then you've got, so passive movement, so you did feel, so now you're doing move. So that's the one we just talked about. And then you kind of do the same thing for the wrist. It's up to you if you want to palpate everything and then move everything, if that helps you remember. I just kind of liked doing it by area, and that was just how I was taught. So then you do the same thing, so just feel across the wrist, and then move, flexion, extension, also sideways. So ulnar and radial deviation as well. Cool, and then now we're at function and special tests. So there are 5 here. So I just remembered all the grip ones. So grip my fingers, pull as hard as you can, or like don't let go, sorry. Pincer grip. So just, I think the easiest way to do these, because you waste a lot of time kind of trying to give instructions to patients and it doesn't look as clean as it could. So I just kind of do like, copy me, okay, don't let me pull them apart. Okay, copy me, don't let me pull them apart. And then you can ask them to write their name is probably the easiest thing because you're allowed to bring a pen and you have paper, so you can ask them to just write their name. There is a thing kind of in the Clin Skills Guide about testing both sides. So if you get them to write with their right hand, you haven't really tested the left hand. So you can get them to do something with their left hand, or you can just get them to kind of do up a button with both hands. And then prayer, okay, and now reverse prayer sign. Yep. Best thing you can do is just kind of demonstrate all of these things. Even if you decide to explain them, even if you say put your thumb and your index finger together, if you kind of show it to the patient, it just moves a lot smoother. Yeah, that's pretty much it for the hand and wrist exam. It's not really that bad. It's just practicing it. So because you guys have made all the effort to come out here, I reckon practice it on each other. Just kind of get it in your heads, and then we'll go on to the knee exam. So just with whoever's kind of near you. If you have any questions, let me know. Wow. Okay, guys, we might keep going. Do the knee one now. Just quickly before we do, so the main Viva questions for this, so what's the difference between OA and RA? What do you guys think? Do you guys know any of the differences? Yeah? What are other differentiating? So symptom-wise as well. Yeah, so if a patient reports like joint pain, do you know the different patterns, like when they'll have, it's worse when?
Like rheumatoid is better on use worse with rest.
Yes.
And then osteo is worse with use better on rest.
Yes. And then you'll get rheumatoid patients saying it's worse in the morning and they have a lot of stiffness in the morning, whereas osteo only get worse once they start using it. So the idea is you have an inflammatory process, and once you start moving it around, it gets easier, whether that's kind of the cytokines, I'm not really sure. But the thing with osteo is really obvious. You've got no cartilage and you're just scraping bone on bone. So when you're moving it, that's when it hurts. So they won't have any morning stiffness, right? They'd be better when they're lying down and not using it and they've just slept. But rheumatoid, on the other hand, they'll wake up having not used it, so it'll be really stiff. They'll complain of pain then, but then it'll get better during the day. So those are kind of the things they want you to say, is the morning thing and the use thing. You can also say inflammatory and degenerative, that's also good. Then there's also what you find on X-ray, some of the things that are different. Does anyone know any of the X-ray signs for like osteo? Yeah? Yeah? Yeah, narrowing of joint space, yeah? Yes, yeah. And then you can get osteophytes as well as the other important one. Cool. Okay. So knee exam. Same thing. Wash hands, introduce yourself, consent. So I'm just going to be looking at your legs and your knee joint in particular. So I'm just going to have a look, a feel, and a move. Is that okay with you? So that you want them to be exposed. They won't really give you someone in pants. That'd just be incredibly inconvenient for the patient to keep taking them off. But check it. Position them, so lie them down on a bed. While they're standing, you can have a look, or you can get them to stand later if you want. So what you're looking for is the varus and valgus deformities. I don't really... The way I remember this, I don't know if it's really going to help anyone. So if you draw like a midline down the middle, it looks like an L, and then valgus is the one that goes towards the L. That's how I remember valgus and varus. But if you have your own way, that's also cool. So valgus is the knock-kneed, varus is bow-legged. You can also have, if they just have like one leg shorter, they might be leaning one way, so you can look for that sort of stuff as well. Then otherwise you just do the normal things. Surgical scars. Some surgical scars can be really small. If you've had like a ACL repair, they just have like 3 little holes. So just kind of like look out for that stuff. All of this is also on top of your general room inspection. That is super important. I always used to just say, so I'm just gonna have a look, feel, move. So I'm just having a look around the room now. Did you bring any walking aids with you? Because I was like, oh, how do I be obvious enough that they see me without looking like an idiot? So I just said it, like in a casual but very obvious way. So look for scars, look for any swelling, any wasting of the quads in particular. So again, you're just comparing. I mean, you can have wasting on both sides, but wasting is quite obvious, and it'll be obvious in comparison to other sort of parts of their body. deformities we talked about, and any length or asymmetry. We also talked about that. Before you start your exam, ask if they're in any pain right now. Does anyone know what leg we start with if they have a unilateral problem? Yes, start with their normal leg. So feel, same as before. So we palpate the joint. So this is when we do the patella tap test and the bulge sign. Yep. So all of them you essentially take just above the knee joint, push down on the fake pouch of fluid, and then feel if any of that fluid has gone into the patella. Yep, so that's the tap test. You'll feel for like kind of like a fluid bounce. When I used to study this, I was like, this is so made up, and I was just kind of like doing whatever. But then you see it in real life and it's quite obvious. So bulge sign as well, same thing. You go like, I don't know where to be. You start the same as your patella tap test. So patella tap test, we just did this. This time you start with the medial side. You push up the fluid that should be here or not be here. You're kind of moving it into this side. So technically there's nothing here. So when you push back this way, it'll bulge. That's the idea of it. It's actually pretty cool when you see it. But just have like the technique and make sure to do it. So then we keep feeling. So we're now going to palpate the joint margin. So you do this with their leg at 90 degrees. They're theoretically lying down. You basically feel all the way around the knee's joint margin. You're looking for the same things we looked for in the hand and wrist exam, right? So if they have osteo or rheumatoid in that joint or anything. So bony projections, any tenderness, which might mean inflammation, any boggy swelling, etc. And then Baker's cyst, which is like the one everyone remembers. So back of the popliteal fossa, and you do this with their legs straight, and you just feel for swelling. So that's feel. Now we go to move. So we're looking at their mobility and pain as well. Oh, right, what do I mean by this? Yeah, okay. So if they have pain all the time and kind of with every movement, you're thinking there's a problem with the joint. But if they only have pain on like one type of movement, you think it might be like a ligament or a muscle problem or something like that. You'll have a normal exam, it's not super important for you. But I thought if you're going to ask about pain, I might as well mention it. Okay, so first you get them to do it. So can you bring your foot to your bottom for me? Okay, can you straighten out your leg? So you want 0 to 150 is normal range of motion, but people can be normal and hyperextend up to kind of minus 10 degrees. Yep. Then you do it passively. So you do this with your hand over their knee joint because you're feeling for crepitus. I used to just do it twice. So I used to just move, come back, and then the second time really just zoning in on like the crepitus and trying to feel for that. It kind of feels like crackling, or kind of like you have a really like kind of like old joint. It's kind of creaky. And then you move the patella as well. So that's all part of your move. So what have you moved? You've moved the knee joint, and then now we're moving the kneecap. So you just do that medially, laterally, look for discomfort in their face pretty much as well. Cool. So that was look, feel, move. And now we're on to the special tests. So we're just testing ligaments, and then we do function. All of these special tests basically test function unless there's something else left that we haven't tested. In this case, knee has a lot of ligaments. So collateral ligaments run where in the knee? On the sides, yeah. So our test is, I can't move very far. Can you stick out your leg? So our test is moving side and other side. Yep. So one's hand kind of on the side of their knee, kind of up towards the quad, the other one on their ankle, and you're kind of adducting and abducting. A little bit, yeah. But, oh, sorry. Yeah, it's kind of like a technique thing, because I've seen a lot of the orthopods on the wards kind of will just do it straight, and that's how they think it works. And they say it'll give if something's actually wrong with it. But yeah, you can flex it a little bit. And then cruciates, so they're bent, you sit on their leg on the bed, which is a bit dumb, but it's what you do. You pull forward, and then you push back. I'd be on here, and if they move a lot, so there's like specific like millimeters, like 0.4, like 4 millimeters or something, but again, I've heard like it's just like quite obvious if you do actually feel it, which you won't, so just kind of know the technique. Then function, so get them to stand up, look at the deformities, get them to just walk, turn around, come back to you. So you're looking for things like the sort of normal things, any foot drop, are they favoring one side, do they seem to be in pain? If they're old and if they look unstable, you kind of guide them, like you don't help them, but you walk near them in case they fall. Otherwise they'll think you're a bit like insensitive. Cool, so that's that one. That one's a hard exam
for you guys to practice on each other. So I reckon we'll just power through to the MSAL, and then you guys can practice the MSAL. Because that's also one that I feel like kind of we didn't really spend much time on in Clin Skills. So MSAL has a few important screening questions that everyone always forgets to ask, but they're kind of looking for you to ask. So it's those 3 there. Do you have any pain or stiffness in your muscles, joints, or back? And then they ask about ADLs. Can you dress yourself without difficulty? Can you walk up and down the stairs without any problems? So just think you're asking them about their pain, and then you're kind of characterizing the severity of their pain in terms of how it affects their function, which is generally like a good thing to do when you guys take your histories as well. They really like that. It's irrelevant, but like with RESP history, if they have shortness of breath, really important for you guys to ask about like how it impairs their function to characterize it. Cool. Okay, so M is for move. This one's pretty straightforward. You pretty much get them to stand, walk, turn around, come back. Same thing if they're older, unstable, you guide them. And then you're just looking for anything that's sort of off. The most sort of basic things is, are they walking symmetrically? Are they swinging their arms? Because there are some diseases where they won't do that, like Parkinson's, etc. Any leg weakness, foot drop, deformities we talked about, and flat foot. So when they're just kind of standing for you, you can check the flat foot thing if you like, or you can do it all in one go. But that's pretty much it. Walk, turn around, come back. Then we've got spine. So inspect the spine from the back. So this is kind of like an around the world, if you know you've ticked everything off. So you start at the back, then you go to the side, then you look at them in the front. So if you don't end up in the front, you've missed something. So you start at the back. They have these deformities. Again, I have a kind of dumb way of remembering this. So you have a normal spine. Scoliosis is when kind of looking at the back and it's turned sideways. Yep. Whereas kyphosis and lordosis is if you looked at them in the side and something was different. I think of lordosis like you're like praying, so your back goes inwards. So it's when you kind of have excessive inward arch of your spine, and kyphosis is like a hunchback. Cool. So you look for that. The other thing you check for is, are their shoulders level and are their hips level? So if they're not kind of favoring one side. And you can also check the muscles of the back as well. So stand on the side then, you move to the side, and that's where you do the 2 vertebrae test. So Michael, can you stand up? Thanks. So I'm on his side. I find 2 of his back muscles, okay. You'd find 2 of his vertebrae. Tell him to bend over and touch his toes. Feel the distance kind of increase, and it should increase by 5 centimeters is what they say. Yep. I was probably doing that a bit low, sorry. You want to kind of do it at the lumbar region. Then you move in front of them, so finish your around the world. You want them to put their ear on their shoulder without lifting their shoulders. So keep your shoulders down and try and touch your ear to your shoulder, other side, and then that's your lateral cervical function. And that's it for spine. Then the arms and legs are basically very abridged versions of your other MSK exams. They look kind of long when you list out everything that they want you to do, but it's pretty straightforward. So you inspect like before, so you're looking for all of those nodes that we talked about, or deformities, wasting, etc., etc. Then hands by your sides, elbows straight, hands out in front, palms down. Turn over, so you're testing their supination, pronation. Make a fist, so this is kind of like grip strength. Then pincer every finger. Yep. Squeeze the MCPs for tenderness, which we did in the other exam. And then resting position. And then that's your whole arms. There's no real kind of like way I could think of to help you guys remember this. It's just kind of, you have to just do it. Like it takes 30 seconds, so you just kind of have to do it like 30 times before your exam in a row, which will take you like 5 minutes. And just do it over and over again, so you're really smooth with it and you know what you're doing. I practiced on my sister for like 2 days straight before the exam, so if you guys have anyone around you, if they're not medical, it's really helpful. If you don't have anyone like that, then anyone's fine, like mates practice on each other. But if you have someone that's not medical, actually it's really good because you realize how your instruction wording like is or isn't good. So inspect, hands by side, out in front, turn over, make a fist. So we're doing grip strength, so then we keep going to pincer all of the fingers, squeeze, and rest because we're done. Cool. Then legs. The leg one's also quite good. The leg one is look, then you kind of basically move everything, and that's pretty much it. So look, like before, every movement in the MSK is all pretty much passive movement. So you flex their hip and their knee, looking for crepit when you move it. Active is if you got them to move it themselves, yeah.
So flex their hip and their knee. While you're here, you feel for crepitus. Internally rotate the hip. Then palpate patella for tenderness and effusion. You don't need to do the specific tests, you just really palpate it because it's kind of a screening tool. And then you've done the hip, you've done the knee. So because this is a screening test, we do the ankle too. So all you do is just test ankle flexion, extension, the same way. Compress, like we did for the hand. So you compress the metatarsals. And then we also look at the soles of the feet for calluses, which would tell us that there's abnormal weight bearing. So with the leg exam, you kind of think that we're just going all the way down. And once you start testing their ankles, then you're like, oh, yep, I'm here. Let me look at their feet. So it's really important for you to tell them to take off their shoes. Otherwise, you'll get roasted. And yeah, let's practice that one too, I think. Just with the person next to you. If you have any questions, you can ask.
How do you say bend over?
Yeah, it's kind of one of those things you have to test. The thing I could think of, there's not like an explicit thing where they say if they're old do this. You could make them sit like on the patient bed and then bend over from there. And the idea is they just kind of need to be bending, so go as far down as you can, and you can kind of be there to support them if you want. So if you have something like ankylosing spondylitis, if you have something where where your vertebrae fuse, then you won't have that mobility and flexibility. Yeah, so that's kind of what you're screening for.
Wonderful. Okay, so now legs. So again, I would have okay, thank you very much. So I'm going to passively flex your knee. I'm not going to flash around you.
The hip?
What do you think? I don't know if that's like a proper technique. No, as long as you're rotating it. Okay.
Are we measuring to like positive regression? This is 0, then they should come all the way back to like.
Good. Alright. So now we want to know your arms. So if I can get you to take a seat again.
Yeah, so this is the straight line. Yeah, so it's here. This is like a parallel straight line.
Right. Okay. So
If you want to be confused, and go back. This would only kind of take you.
oh, it was in the video.
Oh, right.
Okay.
Break it back.
Yeah. I don't know many people that did that for OSCEs. I mean, I probably have to do it for my eyesight. But yeah, you can do that if you want to be comprehensive. I didn't do it.
Okay.
I don't think I know anyone that I went through it with who was doing it.
Yeah.
It's just like not in our police guys book. But you could if you had time, but like these sorts of things. But it's not one of those things that's really going to change your mark, I think. Yeah.
I just like it's just like
No, that's a fair question.
in my mind.
No, that's fair because this doesn't get there anyway.
Yeah.
No, all good.
Wonderful. So yeah, do
Actually, then I do this with my patient. Can I get you? Yeah. Put your arm back behind you. And then oh, sorry. And you can get it up. Okay. Me?
Yeah, I think that was good.
Mine is
Right, this is someone doesn't
oh. I can press
remembering numbers.
Yes, your number thing is good. So, can I get you to put your hands up around me?
Inspect hands by side, so that would be, that's 1, 2, 3, 4, 5, 6, 7.
Fist as well. Except when you turn over, make a fist.
And then,
When you turn over, make a fist. Yeah.
that one as
And
well.
then do the, yeah.
Okay, so was that 8 then or 7?
Yep.
1, 2, 3, no. 2,
I know.
5, and then oh yeah, pain for pain. Yeah, 3, 7.
So this is a screening app.
Yeah, so it's 8 on the arms, and then the legs is look again. So and then assess like move thing,
Alright.
practice, internal rotation, patella, tenderness and effusion, extension thing, tenderness and calluses, so that's also 8.
Hi.
I love
This
that.
is elevation and external rotation. So, yep, and can I just get you?
Alright.
Wonderful. Alright, so now we get some.
And then I get a
So,
copy
Bill,
before.
can I get you to lie down on the bed?
Oh yeah, me too.
Yes, I want to do that.
Okay.
Um,
Hi, my
Okay,
name's Emily. I'm
so-
a second year medical student. Can I
Bill,
come in?
oh, yep, you can get
Tiffany, it's really
So,
nice to
I'm
meet
going
you.
to start by
So today I'm going to ask you to perform a screening exam on you. And what I'm screening for is any problems in your joints or your muscles. So the test today involves me asking you to do a couple of things for me, like walking back and forward, and then we're going to have a closer look at your joints in your hands and your knees. Start by asking you to walk just a couple of meters that way, turn around and walk back for me.
Tell me when to turn.
Turn.
Okay.
So what are you looking for?
Okay. Valgus, varus, also say sad, scars, swelling, malalignment, deformities, pain, favouring one leg, asymmetry. What else?
What else is specific to walking and not just standing?
Oh, gait.
Yeah, gait and arm swinging.
Yeah, that's a good one. I would have always forgotten that. Okay.
And then feet, flat feet.
And foot drop as well.
Yeah.
Yes.
You'd get them barefoot.
Yes.
Yes,
Yeah.
okay.
Do you want me
And you'll have to do that for legs anyway.
Yeah.
But I'll just remember to do that. So I should have asked you your screening questions. Okay.
No, okay.
So then I guess that negates the other questions. Whether you had trouble dressing or you have trouble getting up and downstairs. Okay. Okay, beautiful. Alright, so now I'm going to do a bit of an examination here. Can you put your hands by your side for me?
Do you want to do spine?
Yep. Okay, so I'm just going to have a look at you from the side and from the back. Just stand up straight.
I think I have kyphosis.
Well, I have a scoliosis appendice, but it's really mild. The only Jess were like, why do you even tell people that? It's not even there.
Oh.
I was like,
That's so mean.
lying. Yeah. I was like, that's not what the X-ray said. Okay.
How
You're good?
how much is yours?
Oh, I have no idea, like a few degrees. But could be of interest. Okay. So now what I'm going to do is I'm going to put my fingers on your back, and then I'll ask you when I found the right spot to bend over. Actually, I have no idea.
I have no idea.
Right. Can you bend over for me? Yeah, no, I definitely didn't do that right. Okay, perfect.
Do you want to try again?
No, it's fine. I'll need to do it on someone who's back and can actually see it, so that I know what I'm doing. Because like my feet, your fingers didn't split then either. Like,
I know, right? Like having some
so can you see? I can feel those bumps on my back.
yeah.
Maybe it's easier back. Alright, perfect. And then, so there were three things just one. So it was the bending, the looking, and
Can you do grip strength in a
there's
MSL?
something else I needed you to do as well.
Yeah, you do it in. Oh right, get them to actually. Yeah, you
Well,
can if you
what's the
like
other
want.
thing?
It's not
Fine.
part of the test.
Oh, no.
Yeah, well, and was it just to get them to do
Oh,
or
yes.
pull every single one?
No.
In the Clin Skills guide, all they need you to do is just do the pincer. I reckon while you're there, you might as well do that
So
stuff.
now I'm going to have a
I
look
would.
at my
I think I
hands,
did it in
right?
my exams.
So,
Yeah,
can
it
you
doesn't
just
take
follow
that
my
long.
movements? So first of all, we're going to put our hands by the
Exactly, for doing
Yeah,
extra.
front.
So I would do it. Yeah.
Perfect. Now turn them over for me. Make a fist. Beautiful. Now can you go like follow my movements? Yeah, perfect. Okay. Okay, so now what I'm going to do, I'm just going to have a bit of a feel like this of your hands. So you can just go like this for me. Is there any pain at all? Okay. And now can you put your hands behind your head for me? Okay, beautiful. Fantastic. Alright, so now I'm just going to look at your knees. Don't actually. You can if you want to, but. Okay. So, 8 things looking for our sad, muscle wasting, and blah blah blah. Okay, and then also I'm going to do actual flexion extension of the hip and knee, crepitus, while I'm doing that.
So mobile for a man your age.
And then I'm going to move down to the ankle. Oh, rotation. Not, yeah, I would definitely include that up here.
Guys,
So,
just really quickly as well, these guys came up with a pretty good. Is it 8 for each thing?
Yeah.
For arms and for legs for MSAL, you have to do 8 things.
Yeah.
So I'll help you remember if you've
8
left
things
something out.
for both.
Yeah. So
Oh.
kind of if you count up everything, it's 8. Yeah.
You're
You're like, yeah. Why do I have 3? Yeah.
Yeah, that's good.
Yeah, yeah. So if you just feel like you can't remember how many things there are.
Okay, no, so I looked, and then I did up and back. Let's just say I was doing it, and then I got up, so that was 2 plus crepitus, that's 3. Internal rotation, 4. Patella tenderness, 5. Ankle, I'm going to move it back and forward, that's 6. I'm going to test for tenderness, and then I'm going to look at the axis. Cool. Beautiful. That's alright. Alright, patella.
Yeah, thank you so much.
Feed myself.
Yeah, it's okay, it's okay.
Alright.
So I have a question, which is when you do like your cerebellar sort of gait, yeah, so that would be in your like peripheral neuro, not your cranial nerves.
Yeah. In peripheral neuro, you have a bit at the end where you do like the whole game.
And I literally just like, and you should be expected to do that, or should you ask? Just because I wasn't really sure if
I was like, no,
Well, yeah, okay. It doesn't hurt to just offer it.
Yeah.
Actually, I think it would.
Because I'm not really sure if it would.
Do you remember if in the guide they write it as part of peripheral neuro? Because they'll kind of change whether you offer it or you do it.
Yeah, bring the guide out because I.
Yeah. Because it's pretty relevant to like a lower limb neuro.
Yeah.
But if you're like pressed for time, you can always just offer it unless it's written in there.
Because this finger stuff is like cerebellar, right? But that sort of to me fits more into like a cranial one in terms of like.
Yeah, you can do. They don't expect you to do the coordination stuff, but you can do that if you want as well. But
Smash it.
Of course. Alrighty, that's all good.
Hey.
Um,
That's what I'm calling.
Oh no. Oh no, it's totally fine.
Yeah.
It's alright, as long as like.
Yeah, no. Yeah.
Do you have any questions about anything?
Can I practice it on you? Is that okay?
Yeah. I had something to go to before, but now it's been pushed back, so I actually don't know. What do you want to practice?
MSL?
Okay.
Okay.
I'm your patient.